Hello, welcome to World of Microbes. In today's video we will discuss about recently spread hantavirus. An extraordinary outbreak of Andes hantavirus aboard the Dutch-flagged adventure cruise ship MV Hondius has resulted in 11 reported cases, including 3 deaths. In this video we will discuss about the structure, clinical aspects, epidemiology, signs and symptoms, timeline and outbreak metrics, its strains, reducing risks, diagnosis, treatment and recovery. Orthohantaviruses, also known as hantaviruses, HTVs, are emerging zoonotic viruses that have been classified by the Centers for Disease Control and Prevention, CDC, as an A-category pathogen that poses a significant public health burden worldwide. People get hantavirus from contact with rodents like rats and mice, especially when exposed to their urine, droppings, and saliva. It can also spread through a bite or scratch by a rodent, but this is rare. More than 20 orthohantaviruses are known to cause illnesses in humans through rodent transmission. Orthohantaviruses are non-arthropod-borne viruses, and rodents or insectivores are the main natural hosts, which can be persistently infected with little or no pathological consequences. They are detected every year throughout the world and are conveniently divided into 2 categories based on the region of the epidemic. In the Americas, infection has been known to lead to hantavirus cardiopulmonary syndrome, HCPS, a rapidly progressive condition affecting the lungs and heart, while in Europe and Asia hantaviruses have been known to cause hemorrhagic fever with renal syndrome, HFRS, which primarily affects the kidneys and blood vessels. While there is no specific treatment that cures hantavirus diseases, early supportive medical care is key to improve survival and focuses on close clinical monitoring and management of respiratory, cardiac, and kidney complications. Prevention depends largely on reducing contacts between people and infected rodents. 1978, the etiologic agent of Korean hemorrhagic fever was isolated from small infected field rodent Apodamus agrarius near Handan River in South Korea. The virus was named as Hantavirus, after the name of the river Handan. This initial discovery dates back to scientific approaches that were initiated after the Korean War, 1951 to 1953, during which more than 3,000 cases of Korean hemorrhagic fever were reported among UN troops. In 1981, Hantavirus strain 76-118, isolated from Apodamus agrarius, was grown in a 549 cell line, and its electron microscopic images revealed that the virus was a new member of the Bunyaviridae family. It was observed that hantaviruses, unlike other members of this family, do not have an arthropod vector, and exclusively establish a persistent infection in the population of their specific rodent hosts. In 1981, a new genus termed as Hantavirus was introduced in the Bunyaviridae family, which included the viruses that cause hemorrhagic fever with renal syndrome, HFRS. It was initially thought that pathogenic hantaviruses are restricted to Old World. Until 1993, the only native hantavirus found in New World was non-pathogenic Prospect Hill virus, PHV. This myth ended after the hantavirus outbreak in the Four Corner region of southwestern United States that caused serious respiratory distress in infected patients and led to the discovery of a new hantavirus disease called Hantavirus cardiopulmonary syndrome, HPS. An examination of frozen stored samples of lung tissue from people who had died of unexplained lung disease in the past revealed that HPS is an old disease with confirmed cases dating to at least 1959. Within a very short period, the virus causing HPS was isolated from common deer mouse and was later named as Sin nombre virus, SNV. Later on, it became clear that other hantaviruses similar to SNV, such as Andes virus, ANDV, are present throughout the United States. Currently, the hantavirus genus includes more than 21 species and more than 30 genotypes. Hantavirus is a potentially fatal viral zoonosis spread primarily through the inhalation of aerosolized rodent excreta, urine, feces, and saliva. Globally, it causes 150,000 to 200,000 infections annually and manifests into 2 primary syndromes: hemorrhagic fever with renal syndrome, HFRS, in Eurasia, and hantavirus cardiopulmonary syndrome, HCPS, in the Americas. On May 2, 2026, WHO received notification from the IHRNFP of the United Kingdom of Great Britain and Northern Ireland, hereafter referred to as the United Kingdom, regarding a cluster of severe acute respiratory illness, including 2 deaths and 1 critically ill passenger, aboard the Dutch-flagged cruise ship MV Hondius. As of May 13, a total of 11 cases, 8 confirmed, 1 inconclusive and 2 probable cases, including 3 deaths, 2 confirmed and 1 probable, have been reported. Since the last disease outbreak news was published on May 8, 2 additional confirmed cases and 1 inconclusive case have been reported among passengers. These are 1 confirmed case from France, who became symptomatic during repatriation, 1 confirmed case from Spain, tested upon arrival following repatriation but currently well and asymptomatic, and 1 case considered inconclusive. The latter was repatriated to the United States of America, is currently asymptomatic with inconclusive laboratory results, 1 positive and 1 negative result from 2 different laboratories, and is being retested. The individual was sampled due to high-risk exposure to confirmed cases on board. All laboratory confirmed cases are confirmed for ANDV infection. All were passengers on board the MV Hantavirus. Based on currently available information, the working hypothesis is that the first case acquired the infection prior to boarding the cruise, through exposure on land. Investigations are ongoing to elucidate the potential circumstances of exposure and the source of the outbreak, in collaboration with authorities in Argentina and Chile. Current evidence suggests subsequent human-to-human transmission on board the ship. This is also supported by a preliminary analysis of the sequences, which show a close, near-identical sequence from different cases. Hantavirus infections are relatively uncommon globally but are associated with a case fatality rate of less than 1 to 15% in Asia and Europe and up to 50% in the Americas. Worldwide, it is estimated that from 10,000 to over 100,000 infections occur each year, with the largest burden in Asia and Europe. In East Asia, particularly China and the Republic of Korea, HFRS continues to account for many thousands of cases annually, although incidence has declined in recent decades. In Europe, several thousand cases are reported each year, mainly from northern and central regions where Pumala virus circulates. In the Americas, HCPS is much rarer, with hundreds of cases reported each year across the continent. The United States of America has reported fewer than 1,000 cases, while South American countries such as Argentina, Brazil, Chile, and Paraguay report small numbers of cases annually. Despite the lower incidence, HCPS has a high case fatality rate, commonly between 20% and 40%, making it a disease of major public health concern. These are members of the genus Hantavirus, family Bunyiviridie, and their species, disease, principle, reservoir, distribution of virus, and distribution of reservoir. These are members of the genus Hantavirus, family Bunyiviridie, and their species, disease, principle, reservoir, distribution of virus, and distribution of reservoir. These are members of the genus Hantavirus, family Bunyiviridie, and their species, disease, principle, reservoir, distribution of virus, and distribution of reservoir. These are members of the genus Hantavirus, family Bunyiviridie, and their species, disease, principle, reservoir, distribution of virus, and distribution of reservoir. These are members of the genus Hantavirus, family Bunyiviridie, and their species, disease, principle, reservoir, distribution of virus, and distribution of reservoir. These are members of the genus Hantavirus, family Bunyiviridie, and their species, disease, principle, reservoir, distribution of virus, and distribution of reservoir. These are members of the genus Hantavirus, family Bunyiviridie, and their species, disease, principle, reservoir, distribution of virus, and distribution of reservoir. Orthohantaviruses are negative, single-stranded RNA viruses with a genome composed of 3 RNA segments, namely, small, S, medium, M, and large, L, which are 1828, 3650, and 6550 nucleotides, and T, long, respectively. The S segment encodes the nucleocapsid, N, protein, the middle, M, segment encodes a glycoprotein precursor, GPC, that is cotranslationally cleaved into 2 viral envelope glycoproteins, GN and GC, and the L segment encodes the viral RNA-dependent RNA polymerase, RDRP. In addition, the S segment of some orthohantavirus species encodes a non-structural, NS, protein. The N protein is the most abundant viral protein synthesized early after infection. This protein is involved in the intracellular transport and assembly of mature virions and facilitates the attachment of the virus to the host cell proteins that direct replication. When encoded, the NS protein inhibits the interferon beta, IFN beta, promoter, which regulates the interferon response. The glycoproteins GC and GN are directly involved in the binding of the cellular receptor and in the entry mechanism. They may also modulate the host immune response. Virus entry occurs through different intracellular pathways in a species-dependent manner. The entry route involves clathrin-dependent endocytosis, exhibited in the prototypical HTNV infection, micropinocytosis, and clathrin-independent receptor-mediated endocytosis. Hantaviruses are enveloped, spherical, or pleomorphic viruses, 80 to 120 nanometers, belonging to the Hantaviridae family. They feature a trisegmented, single-stranded, negative-sense RNA genome, S, M, and L segments, encased in a lipid membrane. Key structures include surface glycoproteins GN and GC and ribonucleoprotein, RNP, complexes. Key structural components. Genome, trisegmented RNA consisting of small, S, medium, M, and large, L, segments, encapsulated by the nucleocapsid, N, protein to form ribonucleoproteins. Envelope, a host-derived lipid bilayer, roughly 5 nanometers thick, that encapsulates the genome. Surface glycoproteins GN and GC, embedded in the lipid bilayer, these form tetrameric spike structures with fourfold symmetry, which are essential for cell attachment and membrane fusion. Nucleocapsid, N, protein, coats the RNA segments to form RNPs. RNA-dependent RNA polymerase, RDRP, encoded by the L segment and packaged within the virion to manage viral transcription or replication. Structure details, shape and size, generally spherical, but can be pleomorphic or tubular, ranging from 70 nanometers to over 300 nanometers. Spikes, the spikes protrude roughly 10 nanometers from the envelope. Stability, hantaviruses are easily inactivated by detergents or solvents that destroy their lipid envelope. The structure of the virus ensures it can survive in the environment for limited periods and infect host cells via endocytosis. Hantavirus replicates in the cytoplasm of host cells using a segmented negative-strand RNA genome, primarily mediated by viral RNA-dependent RNA polymerase, RDRP, which performs both transcription and replication. The process involves cap snatching for mRNA synthesis and a prime-N realign mechanism to generate new viral genomes, with assembly occurring at the Golgi apparatus. Key stages of hantavirus replication: entry and uncoating. The virus binds to host cell receptors, e.g., integrins, via glycoproteins GC and GN and enters via receptor-mediated endocytosis. The viral envelope fuses with the endosomal membrane, releasing ribonucleocapsid, RNP, segments into the cytoplasm. Transcription, mRNA synthesis. The viral RDRP, L protein, uses a cap-snatching mechanism to steal 5-foot, capped primers from host cell mRNAs, which are then used to initiate transcription of viral mRNA. This occurs in the cytoplasm, potentially within viral factories. Translation, viral mRNAs are translated by host cell machinery into structural proteins, nucleocapsid N protein and glycoproteins, GN/GC, and the RDRP. Genome replication, the RDRP uses the negative-sense viral RNA, vRNA, to create a positive-sense complementary RNA, cRNA, intermediate. This cRNA acts as a template for producing new, full-length negative-sense vRNA. This process likely utilizes a prime-N realign mechanism. Assembly and budding, the new vRNA is encapsulated by the N protein. These newly formed RNPs transport to the Golgi apparatus, where they bud to obtain their envelope and are released from the cell. Transmission of hantaviruses to humans occurs from contact with contaminated urine, droppings, or saliva of infected rodents. Infection may also occur, although less commonly, through rodent bites. Activities that involve contact with rodents such as cleaning enclosed or poorly ventilated spaces, farming, forestry work, and sleeping in rodent-infested dwellings increase exposure risk. To date, human-to-human transmission has been documented only for Andes virus in the Americas and remains uncommon. When it occurs, transmission between people has been associated with close and prolonged contact, particularly among household members or intimate partners, and appears most likely during the early phase of illness, when the virus is more transmissible. In humans, symptoms usually begin between 1 and 8 weeks after exposure, depending on the type of virus. Because they closely resemble common viral illnesses, they can be difficult to diagnose without a careful exposure history. Common early symptoms include sudden high fever 101 to 104 degrees Fahrenheit and chills, severe fatigue and weakness, myalgia, intense muscle aches, particularly in large muscle groups like the thighs, hips, and back, gastrointestinal distress, nausea, vomiting, diarrhea, and abdominal pain, headaches, and dizziness. After 4 to 10 days, the illness rapidly progresses depending on the specific strain of the virus. Hantavirus pulmonary syndrome, HPS/HCPS, commonly caused by New World hantaviruses, e.g., Sin nombre, Andes virus. This syndrome progresses rapidly from the initial phase to severe respiratory distress. Respiratory compromise. 4 to 10 days after initial symptoms, the lungs begin to fill with fluid, causing a dry, non-productive cough and severe shortness of breath, dyspnea. Cardiopulmonary phase progresses quickly, often within 24 to 48 hours, to severe respiratory failure and shock. Prognosis. This form is highly fatal, up to 40% mortality rate, and requires immediate, intensive care, including mechanical ventilation or ECMO. Hemorrhagic fever with renal syndrome, HFRS, commonly caused by Old World hantaviruses, e.g., Hantan, Pumala, Sol virus. This form targets the kidneys and blood vessels. Bleeding and renal phase. Following the early fever, patients experience low blood pressure, internal bleeding under the skin, petechiae, and severe kidney dysfunction that can lead to acute kidney failure, Progression. The disease typically cycles through 5 distinct clinical phases: febrile, hypotensive, oliguric, decreased urine output, polyuric, recovery of urine output, and convalescent. Prognosis. Mortality rates are generally lower than HPS, ranging from less than /1% to /15% depending on the specific viral strain. Early diagnosis of hantavirus infection can be challenging because early symptoms are common with other febrile or respiratory illnesses, such as influenza, COVID-19, viral pneumonia, leptospirosis, dengue or sepsis. A careful patient history is therefore essential, with particular attention to possible rodent exposure, occupational and environmental risks, travel history, and contact with known cases in areas where hantaviruses are present. Laboratory confirmation relies on serological testing to detect hantavirus-specific IgM antibodies or rising IgG titers, as well as molecular methods such as reverse transcription polymerase chain reaction, RT-PCR, during the acute phase of illness, when viral RNA may be detectable in blood. Samples collected from patients are a biohazard risk. Laboratory testing on non-inactivated samples should be conducted under maximum biological containment conditions. All non-inactivated biological specimens should be packaged using the triple packaging system when transported nationally and internationally. There is no licensed specific antiviral treatment or vaccine for hantavirus infection. Care is supportive and focuses on close clinical monitoring and management of respiratory, cardiac, and kidney complications. Early access to intensive care, when clinically indicated, improves outcomes, particularly for patients with hantavirus cardiopulmonary syndrome. Preventing hantavirus infection depends primarily on reducing contacts between people and rodents. Effective measures include keeping homes and workplaces clean, sealing openings that allow rodents to enter buildings, storing food securely, using safe cleaning practices in areas contaminated by rodents, avoiding dry sweeping or vacuuming rodent droppings, dampening of contaminated areas before cleaning, strengthening hand hygiene practices. During outbreaks or when cases are suspected, early identification and isolation of cases, monitoring of close contacts, and application of standard infection prevention measures are important to limit further spread.